Okay, hello everyone. Can all of you hear me? Okay, okay, guys. So today,
Yes,
first
sir.
of all, first of all, we are gonna start the cardiovascular pharmacology, right? So first of all, we are gonna do the cardiovascular pharmacology, and it's really easy. Now we are done with the cardiovascular pathology and physiology, so the pharmacology portion is very easy, right? But you have to do a good due diligence on the pharmacology topics because they come a lot in the exams and they are very high, right? So first of all. Uh, So there are certain topics for the cardiovascular pharmacology. Okay. So first of all, whenever a patient is having diabetes, right? So whenever a patient is having diabetes, what kind of heart so we'll do this at the end. We're gonna start from here, right? So we'll start from the nitrates, right? So what are nitrates, right? So there are different drugs that come into the nitrate categories. These are the nitroglycerine, isosorbide dinitrate, or the isosorbide mononitrate, right? So what are the mechanism of action of these drugs? These drugs have a boss. So these drugs have a very easy mechanism of action, right? So what do they do is that they secrete nitrous oxide in the vascular smooth muscle, right? So these drugs are gonna secrete nitrous oxide in the vascular smooth muscle, and when they are gonna secrete the nitrous oxide in this vascular smooth muscle, a molecule which is known as the CGMP, which is the cyclic guanosine monophosphate, that is gonna increase, right? So whenever you give nitrates or nitroglycerin to some patients, the nitrous oxide in the vascular smooth muscle is going to increase, right? And as soon as the nitrous oxide increases, the CGMP is going to increase, right? And that is going to cause the smooth muscles to relax, right? So I have told you guys that whenever the smooth muscle relaxes, you are gonna get so whenever the smooth muscle relaxes, the venous return is gonna relax, right? So the veins are gonna relax, and when the veins are gonna relax, less amount of blood is going to the heart, right? So this is the biggest basic mechanism of action, right? So that is why we use this thing in angina. So first of all, that is why we use these things in angina, because when we use these drugs in angina, the thing that is gonna happen is that less amount of blood is gonna go to the heart. When less amount of blood goes to the heart is gonna contract with less force, and less amount of oxygen will be required to the heart, and as a result, the angina pain will be relieved. It's the same mechanism why we use these drugs in acute coronary syndromes or myocardial infarction to relieve the pain. Because in acute coronary syndrome, there is a lot of pain. So in order to relieve that pain, we use nitroglycerin. Right. And the last way where we use these drugs is the pulmonary edema. Right. So why do we use these drugs in pulmonary edema? Because in pulmonary edema, the same thing happens. Right. So whenever a patient is having pulmonary edema, that patient is gonna have a lot of fluid in the heart, when we need to remove the fluid, we need to redirect the fluid away from the heart. And the best way to do that is to relax the smooth muscles. When the smooth muscles will be relaxed, the veins are gonna be relaxed. As soon as the veins are gonna be relaxed, the patient is gonna feel much better, right? So, what is the first side effect that is gonna occur when you are giving the patient nitrates, right? So, the most important side effects is reflex tachycardia. So, what is reflex tachycardia? This is a very important concept that you guys need to know, right? So our blood pressure is made up of two things. Right? So our blood pressure is made up of two things. One is the cardiac output and other is the heart rate. Right. So now there are mechanisms in the body that regulate the blood pressure. So there are a lot of mechanisms in the body that are going to regulate the blood pressure. So for example, what if I decrease the cardiac output? So what if I decrease the cardiac output? So in order to maintain the blood pressure, the heart rate is going to increase. This thing is known as the reflex tachycardia. In the same way, if I decrease the heart rate by giving beta blockers or calcium channel blockers, then what is going to happen is that cardiac output is going to increase. Right. So cardiac output is going to increase. If you decrease the heart rate, the cardiac output is going to increase to compensate for the low blood pressure. So these people have reflex tachycardia. So we need to control that reflex tachycardia. And the best way that we can control that reflex tachycardia is the help of beta blockers. So beta blockers are going to control the heart rate. They are going to act on the SA node and the AV node, and they are going to reduce the heart rate and control the reflex tachycardia. Right? So we usually give nitrates always with the beta blockers. This is a very important thing. Now, the second thing that is important here is mm, that is headache, right? So flushing and headache. Why is that important? So this is related to the concept which is known as the tolerance, right? So whenever we give, so especially so whenever we give certain drugs has the capacity to become, so body have an ability to become tolerant to certain drugs, right? So our body have the ability to become tolerant to certain drugs, and that ability is known as the tolerance, right? So when the body becomes tolerant, the body is no longer gonna work against those drugs, right? So nitrates are such drugs against which the body develops tolerance very quickly. So if you give nitrates straight for 5 days, the nitrates are not going to work on the sixth day. And this thing was seen in the workers of England, right? So whenever those patients were working in the factories for 5 days, those people did not get anything, right? Now there was nitrate in the factories, right? So nitrates usually causes headaches, right? So those people develop tolerance for the vasodilating action during the work week, and and over the weekend there was loss of tolerance. So when they went back on Monday again, those patients had headache, and that headache was eventually gone away, and that came back on Monday. Right now, important thing here is that you cannot give nitrates in the right ventricular infarction. I have told you why you cannot give nitrates in the right ventricular infarction, and at the same time you cannot give nitrates in hypertrophic cardiomyopathy as well, because in both of these conditions if we give the
Sir,
yes.
can you please explain why we don't give it in right ventricular infarct and hypertrophic cardiomyopathies?
Okay, so the reason I told you that, so in right-sided heart failure, the thing that is happening is right side of the heart is not working anymore, right? So when right side of the heart does not work anymore, the problem that is going to happen is that, so if right side of the heart is not working, it is not gonna say send blood to the left side of the heart, right? So preload is basically the amount of blood that is present in the left side of the heart. So the amount of blood that is going to the left side of the heart is very low already. Now, if we give these patient nitrates, the thing that is going to happen is that these patients will have more amount of decreased preload. Why? Because the nitrates are gonna relax the smooth muscles of the veins, and the veins are not gonna contract. And when the veins are not gonna contract, no amount of blood is going to come to the heart, and the heart already needs more blood in case of right ventricular infarction. So that is why we do not give nitrates. Now, in the same way, in right ventricular hypertrophy or hypertrophic cardiac myopathy, again the same thing is gonna happen. Why? Because in hypertrophic cardiomyopathy, the heart already does not have enough blood, right? So we need to give more blood in case of right ventricular hypertrophy, right? Or a hypertrophic cardiomyopathy. So in case of hypertrophic cardiomyopathy, we avoid any drug. So in case of hypertrophic cardiomyopathy, we avoid any drug that is gonna decrease the preload or that is gonna cause blood loss or fluid loss from the body. So we can give the patients beta blockers, sorry, we cannot give the patient ACE inhibitors, diuretics, and nitrates. Right? Now the third thing is there is a drug class of drugs that is known as the PDE5 inhibitors, right? And the most common drug here is the sildenafil, right? So we have a drug which is known as the sildenafil, and that is the PDE5 inhibitor. So what happens when we give a patient PDE5 inhibitor, that is sildenafil, right? So whenever we give the patient sildenafil, so sildenafil is given for the treatment of erectile dysfunction, right? So if a patient is having erectile dysfunction, we are going to give that patient sildenafil. Now the problem here is that sildenafil also works on the same receptors, right? So sildenafil also relaxes the vein, and as soon as the veins get relaxed, you are gonna have the same problem again, right? Decreased amount of fluid is gonna come to the heart. So if you are giving two drugs at the same time, both of which act on the veins and decrease the amount of blood that is coming to the heart, the patient is gonna go into collapse because no blood is going to come to the heart and the patient are going to have very bad symptoms. So this is very hygiene, keep this in mind, this is very clean, this is so important clinically, that whenever a patient comes to you, so whenever a patient comes to you and that patient is on sildenafil, or if the patient is on nitroglycerin, and they are going to ask you what is the treatment of erectile dysfunction. So the treatment of erectile dysfunction is PDE5 inhibitors, that is sildenafil. We are going to go into the detail of sildenafil and reproductive pharmacology. But right now, remember, for erectile dysfunction, we are going to give sildenafil, and if we give sildenafil with concurrent use of nitrates, the patient is going to get hypertension, the patient is going to die. Okay. Now the next drug we have is calcium channel blockers, right? So what do calcium channel blockers? So
Dr. Moss, please could you please explain the The Monday disease once more.
Okay, right. Okay. So, guys, I told you that nitrates are such drugs that can develop tolerance very quickly, right? So, what happened was that nitrates usually cause headache. And why do nitrates cause headache, right? Because whenever you decrease blood pressure, and so nitrates basically vasodilate, right? And if there is any kind of vasodilation in the head, there is gonna be headache. So that is very easy. But the main problem was that when people work in nitrate factories, so nitrate is used in matchsticks and it is used in firearms and it is used in bullets also, right? So when those people were working in the nitrate factory, what happened was that when they went to the business on Monday, they were having headaches, right? They got headache when they went to the factories. But as the days passed by, as Tuesday came and Wednesday came and so on, they developed tolerance to nitrates, right? So they developed tolerance to nitrates, and at the third or fourth day, those patients did not have any kind of headache anymore, right? So this was the problem that was occurring with nitrates. So, and again, when they went back on Monday, so there was a holiday of Saturday and Sunday. So nitrates lost their tolerance in 2 days. And when they went back on Monday, they had again symptoms of headache. Right. So the scientists were very baffled, the physicians and the doctors were very baffled that what was this disease. But later on, we came to know it as the Monday disease, and it was because then they had developed a tolerance. Right. So this was the Monday disease. Now, calcium
Mhm.
channel blockers. So what are calcium channel blockers? Calcium channel blockers are very easy, right? So if you have any muscle in the body, if you have any smooth muscle in the body, or if you even if you have a skeletal muscle in the body, that muscle is gonna need calcium to contract. Right. So if there is any muscle in the body, that muscle is gonna need calcium to contract. If we cannot give calcium to that muscle, what is gonna happen is that that muscle is not gonna contract anymore, right? So if we get calcium channel blockers in the heart is not going to contract anymore, right? So calcium channel blockers block the calcium channels, no more calcium gets in, and when no more calcium gets in, the thing is that your heart is going to contract very little, right? So these are known as the calcium channel blockers. Now these calcium channel blockers, so now these calcium channels are also present in the vascular smooth muscles. So when we give, now remember, blood pressure comes from the tone of arteries and arterioles, right, and veins, etc. So what if we give a drug that inhibits the tone of arteries? The thing that is going to happen is these patients are no gonna more have high blood pressure. So that is why we use calcium channel blockers as antihypertensive agents, right? Because whenever you give calcium channel blockers, the muscles of the arteries or the veins are not going to contract anymore, and when they don't contract, the arteries are going to lose their tone and the blood pressure is going to decrease, right? Now, the most important thing is that there are three different types of calcium channel blockers. One, and this is very high yield, so remember this thing. One are the dihydropyridine calcium channel blockers. These include amlodipine, nicardipine, nifedipine, and these usually act on the vascular smooth muscle. Right. So the first type of calcium channel blockers are um, the dihydropyridine channels, right? Blockers. Now these drugs will act on the vascular smooth muscles, and there will be a lot of questions in the UL that will mention this. That we have given him lodipine or we have given nicardipine. What will be the mechanism of action? Right. So these are not going to act on the cardiac muscles. These are going to act on the smooth vascular smooth muscles. Now the next type is verapamil. So verapamil is a drug that is only going to act on the cardiac smooth muscles. Right. So verapamil is only going to act on the cardiac smooth muscles, right? And it is only going to affect the heart. So verapamil will reduce the contractility of the heart, right? And the third one is the diltiazem, right? So diltiazem is going to work both on the heart and the vascular smooth muscles, right? So diltiazem again will work both on the heart and the vascular smooth muscles. Now why do we use these drugs? First of all, if a patient is having hypertension, I already told you that in hypertension we can give dihydropyridine calcium channel blockers, and we can give and for angina we can give dihydropyridine calcium blocker as well. Why? Because these calcium blockers are going to increase the blood supply of the heart by causing less constriction of the arteries. Now there is another phenomena which is known as the Raynaud's phenomena. So what is the Raynaud's phenomena? So Raynaud's phenomena is a disease. We are going to study it in the musculoskeletal system, but I'm going to briefly touch it here. So Raynaud's phenomena basically means that there are different arteries in our hands, right? sometimes these arteries, the smooth muscles of this artery contract all of a sudden, right? So different arteries in our hands and the smooth muscles of those arteries contract all of a sudden. And whenever a vessel and whenever an artery is gonna contract, whenever the smooth muscles in the arteries are gonna contract, we are gonna get the whitish discoloration of the arteries. This thing is known as the Raynaud's phenomena, and this is exacerbated or this is exaggerated if we give the patient, if we dip their hands in water, right? Or if we give them a cold condition. Now, how can we treat this condition? So we can give the patients beta calcium channel blockers, and as soon as we give the patients calcium channel blockers, those smooth muscles are not gonna contract again. And when they do not contract again, the problem of Raynaud's phenomena is gonna be solved. Right, so dihydropyridine dilates the arteries and it's going to solve these problems. Then we have a special drug which is known as the nimodipine. And why is nimodipine important? Nimodipine is important because sometimes we have an hemorrhage which is known as the subarachnoid hemorrhage. Right. So whenever we have a subarachnoid hemorrhage in the body, 7 to 10 days after subarachnoid hemorrhage, the vessels that are bursted in the subarachnoid hemorrhage, they are gonna contract very severely, right? So after 7 to 10 days they would remember that, oh my god, we have to contract, and they are going to contract very severely. So as soon as they start to contract, you are gonna get an ischemia, right? You are gonna get ischemia, right? So remember, whenever vessels contract, you are gonna get ischemia. That is very simple. So nimodipine is the drug that would prevent these vessels to contract, right? So these vessels are not going to contract anymore and the patient would have no more ischemia. So that is nimodipine, right? Now there is another drug which is known as the nicardipine and clevidipine. Right? So nicardipine and clevidipine is used in, so these are the IV drugs, IV form of calcium channel blockers. This is very important. So nicardipine and clevidipine is the IV form of calcium channel blocker. So whenever we use these drugs, what is going to happen is that the patient is not the patient won't have uh, high blood pressure, right? So in emergency situations in which oral forms will take longer to work, we give the patients nicardipine and clevidipine. And when we give the patient nicardipine and clevidipine, the patient is going to improve, right? Now the last drug. So now what do we use the verapamil for? So we use the verapamil for angina, or we can use it in any kind of supraventricular tachycardia. Because I told you that supraventricular tachycardias or arrhythmias that were in and originating from the atrium came from the SA node, right? And in order to control the rate of the SA node, what we can do is that we can give these patients these calcium channel blockers, because these calcium channel blockers act on these SA node. And as soon as we give the patients these calcium channel blockers, this problem is going to solve away. Right, now the side effects. So the most important side effects is gingival hyperplasia. So there are two main drugs. One is the phenytoin, another is the calcium channel blockers. Right. So, and third is the cyclosporine, right? So cyclosporine, we give cyclosporine for transplant rejection, right? Let's just give me 1 second. You're not done. Okay, so guys, I was telling you there were three main drugs that caused gingival hyperplasia, and NBM is left to concept these test these three drugs. The one three drug is the first drug is cyclosporine, right? So where does cyclosporine act? So cyclosporine is used for immunosuppression, right? So mark these three drugs, they are important. The first one is cyclosporine. It is used for immunosuppression and it causes gingival hyperplasia. The second one are calcium channel blockers, and the third one is phenytoin. So phenytoin is used to control seizures, right? So we use phenytoin to control seizures, and again phenytoin can lead to um this problem as well, right? So the problem with gingival hyperplasia. Now we have dihydropyridine calcium channel blockers. So dihydropyridine calcium channel blockers is a very important adverse effect, and that is peripheral edema, right? So keep peripheral edema in your mind. Why? Because they are gonna give you a lot of question that the patient came for hypertension, and now that patient has pre-tibial edema. So the patient has edema in front of the tibia. So and then they are gonna ask you what is the most likely cause of this edema, right? So the most likely cause of this patient's edema is calcium channel blockers. Right? These patients are gonna be having edema due to calcium channel blockers.
सर आपने अभी क्या बताया कि a patient present with hypertension or with heart issue and peripheral edema.
Can you repeat
Which
your
is
question?
edema?
Can you repeat your question?
Sir, you made a scenario about the peripheral edema. Can you
Yes.
repeat that?
Okay, so I was saying, so right, so peripheral edema can occur due to a lot of causes, right? There is not a single cause that can lead to peripheral edema, right? So heart failure causes peripheral edema as well. But I am giving you a scenario of a patient who is just having hypertension, right? So what if a patient with hypertension who is just having hypertension comes to you and that patient is having peripheral edema and you are treating him with some drugs? Then they are going to ask you what is the drug that leads to peripheral edema in the patients in these patients, right? So there are a lot of other scenarios that can cause peripheral edema as well. But in the context of hypertension, and if the patient is having no other disease, right? So you are sure that it is not due to heart failure or any other cause. Peripheral edema is gonna be due to dihydropyridine blockers. This is very important. Now they're gonna ask you how do you treat this peripheral edema? This is the second important question. So this peripheral edema is gonna be controlled by ACE inhibitors, right? How do you gonna they get opened, right? So the capillaries are the three capillary arteries against diabetic number.
Yeah, your voice is
Yeah, your voice
is
is breaking,
breaking.
Dr. Moss.
Your voice is breaking. Yes, we can't hear you.
Mhm. Yeah, is it better now, guys?
Yes.
Okay, so guys, I was telling you that. Okay, so guys, I was telling you that these patients have peripheral edema, right? And what is the pathophysiology of this peripheral edema, right? So this peripheral edema occurred due to the fact that calcium channel blockers bl- dilate the smooth muscles, right? So the calcium channel blockers are going to dilate the smooth muscles arterioles, right? So the calcium channel blockers are going to dilate the smooth muscles. They are going to dilate the arterioles, right? So when the arterioles are going to get dilated, right? So when the smooth muscles they are going to get dilated. So the thing that is going to happen is these patients won't have they will have increased amount of fluid that will come into the capillaries, and when that increased amount of fluid is going to come into the capillaries, these patients are going to get edema, right? So this is the way that these patients are going to have edema. The second thing is that how right, so how do we solve this problem, right? So how do we solve the problem of peripheral edema in a patient who is having calcium channel blockers? So the way that we can solve is we give the patient we can give the patient ACE inhibitors. So we can give the patients ACE inhibitors. Guys, these drugs are really high yield, and these factoids alone can have a lot of questions on them, right? So now, second thing is that again, these patients are going to have flushing, and these patients are going to have dizziness, right? Now, what are the non-dihydropyridine calcium channel blockers? Verapamil is a type of non-dihydropyridine calcium channel blocker. So when you are going to give the patient verapamil, that patient can have cardiac depression. That patient can have AV block. Why? Because I already told you that verapamil acts on the AV node and the SA node. So when verapamil acts on the AV node and the SA node, there is going to be AV block. There is going to be SA node block as well. Now, one important thing that these patients can have is constipation. Why? Because the verapamil acts on the smooth muscles, right? And it decreases the contractility of the smooth muscles, right? So our GIT tract has smooth muscles as well, and when and the GIT tract and the food in our GI tract normally moves by the contraction of the smooth muscle, right? So if we give a lot of calcium channel blockers to these patients, the food is not going to move, right? And there would be constipation. And the last thing that is very, very, very high yield is hyperprolactinemia, right? So the side effects of the drugs, their mechanism of actions are really important, right? And why do they act in certain ways, and what are the reasons for certain side effects, and what drugs and what ways we can prevent these side effects, right? So this is very important. Now, the next drug that we are having is hydralazine,
Sorry,
right?
sorry. The last side effect after constipation is hyper what?
So yeah, okay. So
Sir,
guys, I'm not sharing the screen. Yes, yes, yes.
Not
I'm
clear.
listening.
Your voice.
Yep. Okay. Yes. Right.
Hyperprolactinemia. Okay.
And sorry, Dr. Moss, what is the mechanism of hyperprolactinemia?
Okay, guys. So right now, the hyperprolactinemia occurs due to an idiopathic mechanism of action, right? So right now, nobody knows why verapamil leads to hyperprolactinemia, right? So that mechanism of action is not clear, right? And that is not going to be tested, right? So the hyperprolactinemia mechanism of action is not clear for verapamil, right? For the drugs, it's clear that it acts on the dopaminergic pathways, but for verapamil, it's not clear, right? So the second thing is that what was the other question? So there was another question. What was that?
it was about constipation.
Yes. So why is there constipation? So constipation was due to the fact that we need the muscle activity. So remember this thing. This is going to help you in a lot of ways, right? So you need smooth muscles of the GI tract to contract, and when those smooth muscles contract, you are gonna get movement of the GI tract. You are gonna defecate, you are gonna get your feces out, right? You are gonna get your food moving, and all of those things are gonna happen, right? Now there are certain things that you can do to increase the activity of the smooth muscles, and there are certain things that you can do to decrease the activity of the smooth muscle, right? So the most important thing is whenever there is parasympathetic stimulation, the activity of smooth muscles are gonna increase, and you are gonna get increased amount of GI activity. And if you have sympathetic activity, that thing is gonna decrease. So keep this thing in your mind. The second thing is that whenever you give the patient calcium channel blockers, again, the smooth muscles will not contract anymore. Right. So when you give the patients calcium channel blockers, the smooth muscles are not gonna contract. Right. And when the smooth muscles do not contract, the patient is gonna have constipation because the GI tract is not moving. Right. So I think everything is clear till now. Any question?
So for that, what can we use to control the side effects of constipation? Can we give the what's it called laxative?
Laxatives?
Yes, so we can give the patients laxatives, right? So we can give the patient cellulose fibers or polyethylene glycol or sorbitol or methyl cellulose. We can give any of these things to the patient, right? But the main thing is that this constipation is gonna get resolved on its own, right? Because a lot of normally the GI tract will get tolerated to a lot of drugs, right? So the GI tract will be tolerated to these drugs, and it will go away on its own, right? So, but we can give laxatives or polyethylene glycol or cellulose or sorbitol to control this problem, right? Any other question?
Yes, sir. Yes, doctor.
Yes.
Please, can you just, yeah, what's the relationship with prolactinemia and verapamil, please?
Right. So there is no as such defined mechanism of action or the reason that why verapamil causes hyperprolactinemia. But this is a very well-known fact that patients who are being treated with verapamil, they develop hyperprolactinemia, right? So they can give you this question in a lot of ways. Let me tell you how they could give you this question. Right. So they could tell you that a male has come to you and that male was being treated for hypertension, but now all of a sudden this male is having decreased libido, right? And there is decreased erections of the penis as well, right? And the patient is very slow and the muscle mass is decreasing as well. And then they're going to ask you, and then they're going to give you a value that the prolactin level is increased, right? And then they are going to ask you, what is the most likely problem? And when you will see the medication lists, there would be 10 medications or 11 medications, and one of the medications would be verapamil. So you would come to know that this patient is having hyperprolactinemia because of verapamil. They're not going to ask you for the mechanism of action or how does verapamil leads to that, right? The second thing is that they could give you a female and they could say that a female comes to you and that female is being treated for hypertension, and now all of a sudden that female is having whitish discharge from both both spreads. Right?
Rest.
So the patient is having whitish discharge for both spreads, and then they're going to ask you what is the most likely cause of this discharge. So the most likely cause of this discharge is going to be hyperprolactinemia again, right? And that is going to be due to verapamil, right? So any other questions?
Thank you.
Welcome. Okay, so now again, I told you that CGMP was a thing. So CGMP, cyclic guanosine monophosphate, is a compound, is a molecule that causes relaxation of the smooth muscles. Right. Now we have smooth muscles in the arteries and the veins as well. Right. So this is an important difference that you guys need to remember. If we give uh, nitroglycerin, if we give nitroglycerin is gonna act on the smooth muscles of the veins, right? They ask this question a lot, right? So in U World, NBMEs, everywhere, this question will be there, right? So they're gonna say that we have given the patient nitroglycerin. Where does this drug acts? So this drug is gonna act on the smooth muscles of the vein. Again, I am telling you, nitroglycerin is going to act on the smooth muscles of the vein. This is very important, right? Now there is another drug which is known as the hydralazine, right? And hydralazine is going to act on the smooth muscles of the arteries, right? Hydralazine acts on the arterioles, right? So there were two things. One was the blood pressure and the other one was the preload. Blood pressure was related with the afterload, right? So when we give the patients nitroglycine, okay, so can anyone tell me when we give the patients nitroglycine, what parameter of the heart is going to be decreased? What physiological changes are going to
Preload.
occur?
Preload.
Right.
Preload
Preload is
and
decreased.
The
afterload.
preload.
Okay, remember this thing. Remember
Preload
this
and
thing.
afterload,
Once,
yeah.
yes, so 1%.
Because it reduces the heart.
Okay, this was very important. This was what I was looking for. Right. So this is the thing that I was looking for, right, guys? So remember, you guys told me that it reduces the preload, and somebody told that it reduces the preload and the afterload, right? So remember, afterload is due to the contraction of the smooth muscles of the arteries, right? Afterload is due to the contraction of the smooth muscles of the arteries, and preload is due to the contraction of the smooth muscles of the vein, right? So in order to decrease the afterload, we are going to give such drug that acts on the smooth muscles of the arteries, right? Not the veins. And nitroglycerin only acts on the smooth muscles of the veins. It does not act on the smooth muscles of the arteries, right? So nitroglycerin is not going to reduce the afterload. Now we need a drug that is going to reduce the afterload. So scientists and physicians were in search of a drug that reduce the afterload and not the preload. Why? Because there are certain diseases in which we cannot reduce the preload. We just want to reduce the afterload, right? And then we came up with the drug that was hydralazine. So hydralazine also release CGMP, and that also cause smooth muscle relaxation. So the mechanism of action of hydralazine and nitroglycerin are almost similar. The only difference between these two things is that hydralazine acts on the arterial smooth muscles, whereas hydralazine acts on the arterial smooth muscles, whereas nitroglycerin acts on the venous smooth muscle. So hydralazine is going to decrease the afterload, whereas the nitroglycerin is going to reduce the preload, right? So keep these things in your mind. When do we use hydralazine? So I told you, especially hydralazine acts on the arterioles. And if you remember from our first cardiovascular physiology lecture, you know that arterioles contribute to 90% of the blood pressure. So 90% of our body's blood pressure is going to come from the arterioles. Now, what do we do is that in order to control the blood pressure, the most effective medication is the one that is going to act on the arterioles. Calcium channel blockers act on the arterioles as well. And this thing, hydralazine acts on the arterioles as well. So if a patient is having very severe hypertension, we can give the patient hydralazine, right? And if a patient is having heart failure that is not controlled with nitroglycerin and all of other drugs, we can give hydralazine. Why? Because hydralazine is going to reduce, when reduce, the patient is going to have less amount of uh, guys. No, so mainly hydralazine is going to reduce the afterload. It won't reduce the preload so much, because in order to reduce the preload, the drug has to act on the veins. But hydralazine is only acting on the arterioles, so it's only going to decrease the afterload. Right now, second thing is that hydralazine is safe to act during the pregnancy. Right? And the third thing is that whenever we reduce the blood pressure, the cardiac output is going to increase. So whenever we use the blood pressure, the heart rate is going to go up, right? And in order to control the reflex tachycardia, hydralazine and nitroglycerin, both of the drugs causes reflex tachycardia. We give beta blockers with both of these drugs. And the last thing is that the hydralazine is safe during the pregnancy. What drugs are safe during the pregnancy? Hydralazine, nifedipine, right, and labetalol. These are the three antihypertensives that we can give during pregnancy. I'm repeating again. We can give three antihypertensives during the pregnancy. One is hydralazine, other is labetalol, and the third one is one is hydralazine, the second one is the betalol, and the third one is nifedipine or the or the calcium channel blockers. We can give these drugs in pregnancy, right? Now, what are the side effects? The most important side effects is that it causes tachycardia, right? It causes tachycardia, causes reflective tachycardia, right? Second thing is that again, any drugs that causes vasodilation, right? I'm repeating, any drug that leads to smooth muscle relaxation, any drug that causes vasodilation, that drug is going to cause headache as well. And the last and the most important one is that it's to drug-induced lupus erythematosus, right? To drug-induced erythematosus, keep this side effect in your mind, right? Keep this side effect in your mind. Now, let's move to the last. Now, let's move to the
The side
hypertension.
effect in here.
Yes.
Could you say
Okay.
again the same of academic?
Okay. So I was saying that hydralazine causes drug-induced lupus erythematosus. Can anyone tell me what is in lupus erythematosus, systemic lupus erythematosus?
Is
Type 3 hypersensitivity reaction, where immune
Yes.
complex is deposited in different parts of the body.
Yes. So, systemic erythematosus is a disease, is an autoimmune condition in which a lot of immune complexes are formed in the bodies and antibodies are formed in the bodies that is going to lead to anemia, is going to lead to malnourished, that is going to lead to weight loss, right? So systemic lupus erythematosus is going to cause all those problems, right? So now they could give you a question
Your
that a
voice
patient
is
was
breaking a
started on
lot.
hydralazine for
Uh, hello?
severe heart, right? Okay, just give me a second. Okay, is it better now?
yes.
Yes, better now.
Okay. Now, so I was telling that, okay. So I was telling that they could give you a scenario that a patient comes to you and that patient is having malar rash, right? So the first thing that they could give you is that patient is having malar rash, that patient is having weight loss, that patient is having fever. And when you check the CBCs, the patient is going to have anemia as well, and the WBCs are going to be decreased as well, right? And so these are all the signs and symptoms of systemic lupus erythematosus, and the patient is going to have joint pain as well, right? And then they would say you that this patient was starting on hydralazine for severe hypertension, right? So the patient came into emergency department, and we started the patient on hydralazine, and the patient started to have all of those symptoms, right? And then they could ask you, what is the likely mechanism? What is the cause of this thing? So the cause of thing is gonna be drug-induced lupus, and hydralazine is a very important cause of drug-induced lupus, right? Now, the thing is that is important is antibodies uh, systemic lupus erythematosus. There are two antibodies. So the number one is anti-nuclear antibodies, right? Right. So the first antibodies is the anti-nuclear antibodies that are common in patients with new drug-induced. That is common in patients with systemic lupus erythematosus. Guys, can't you hear me?
And the other,
Guys, can you hear me?
Anti-nuclear
It's
antibody.
breaking.
Yes, we can, but sometimes its voice breaking.
Okay. So I was saying that there were two antibodies. The first one was anti-nuclear antibodies, and the second one was anti-double-stranded DNA antibodies, right? So let's first keep this thing in mind. So there was anti-nuclear antibodies, and the second one was anti-double-stranded DNA antibodies. So both of these antibodies were common in people that were having systemic lupus erythematosus. But there is a very big difference in patients who are being treated with drugs and they develop drug-induced lupus, right? So those patients are gonna have antibodies that are common, that will be anti-histone antibodies, right? So they are gonna have anti-histone antibodies. And so if whenever for so don't worry, we are gonna go systemic lupus erythematosus in detail during the musculoskeletal system. But I think some cases, some questions regarding this is gonna come in the U world as well, in the cardiology portion as well, because steps are integrated, right? So if they give you a patient and they say that this patient's anti-histone antibodies are positive, then the systemic lupus erythematosus is gonna be due to drugs, right? So the anti-histone antibodies are very important. Now, what is hypertensive emergency? I've already told you that hypertensive emergency is a condition in which the blood pressure is more than 180 by 200, right? So, what are the drugs that you can give if you are working as a physician in the US? What are the drugs that you can give to the patient? Right. So the first drug is labetalol, which is a beta blocker. So you have to give IV drugs, right? So the first drug is IV labetalol. The second drug is IV nicardipine or clobazam. We have already discussed that, and we can give the patient nitroprusside as well. So what if I ask you what would be the mechanism of action of nitroprusside? Can anyone tell me?
Ompa.
Mm, both.
Is both
It's
arteriolateral and venous
both,
related.
like arteries
Pro
and veins.
GMC,
Vasodilator.
cyclic GMC mean.
Okay, and what
Cyanide.
about yes? So what about
Cyanide.
yes? So what about hydralazine?
Just
Hydralazine
hydrazine is
direct
on
pure
this
arteriodilator.
arterioles more.
Okay, right. So we can give hydralazine as well, right? So nitroglycerine. So one more important thing regarding nitroglycerine is that nitroglycerine is gonna cause cyanide toxicity, right? So how does cyanide toxicity presents to you, right? So first thing is that remember, if a vasodilator acts more on the veins, it is gonna be nitroglycerin. If a vasodilator acts more on the artery, it is gonna be hydralazine. But if a vasodilator acts both on the veins and the artery, it is gonna be nitroprusside, right? The second thing is that there is another case scenario that can come here, and that is if a patient was being treated for severe hypertension and that patient was treated with a drug that acted both equally on the arteries and veins, and now that patient is having all of a sudden cherry red discoloration of the skin. So the first thing is the patient is having cherry red discoloration on the skin. That patient is having dyspnea as well, right? So the patient is having dyspnea as well. That patient is having cherry red coloration of the skin, right? And then you start to do the patient's pulse oximetry, right? So you think that you have to do the patient's pulse oximetry, right? And when you do the patient's pulse oximetry, you find that the pulse oximetry is normal, right? And but the patient is having very low breath, the patient is having dyspnea, the patient is having functions of confusion, agitation, vertigo, right? The patient is having flushing of the skin, which is known as the cherry red skin. What thing should come into our mind, right? Can anyone tell me?
Cyanide toxicity,
It's
and
cyanide.
also there will be
Yes,
Cyanide
so
acidosis,
toxicity.
yes,
metabolic
yes. So
acidosis.
that is how cyanide toxicity is gonna present, and that is how, guys, I want you to remember the U world and the first aid, especially the first aid. When you look at the first aid, when you look at a certain line of the first aid, so then you should not only remember that nitroprusside is gonna cause cyanide toxicity. You should have a picture in your mind that what would a patient who is being treated with nitroprusside and all of a sudden he gets a side effect, how is that patient gonna present to you? So remember the clinical picture. Make a video or a picture of every drug that you are studying in your mind and think what will be the how will this patient present with this drug, right? Make a video, make a picture, make up a thing in your mind and think, oh my god, how is this patient gonna present in the exam, right? So this is a very important thing that you should keep in your mind, right? Now, what is the treatment for cyanotoxicity?
Cobalamin injection
Hydroxycobalamin,
IV also.
Sodium
sodium nitrite.
thiosulfate. Sodium
So
thiosulfate.
Sodium.
yes, so there was a lot of drugs. So we use sodium nitrite, amyl nitrite, sodium thiosulfate. But now the main drug that we use is hydroxycobalamin, right? So now we are going to use hydroxycobalamin, right? Now the second thing is what is the pathophysiology of cyanide poisoning? How does cyanide poisoning occurs?
It
Pathophysiology.
affects oxidative phosphorylation somewhere. I don't exactly remember.
Right.
I
So
think it's
basically,
competitively inhibit.
yes. So basically, it's gonna inhibit the cytochrome complex 4, right? And it's gonna cause blocked oxidative phosphorylation, right? So cyanide blocks the oxidative phosphorylation, and once the oxidative phosphorylation is blocked, the patient is going to have anaerobic respiration and lactic acidosis. Right? So all of this is going to be due to nitroprusside. Now there is another drug which is known as the phenyldopam. Right. So what is phenyldopam? Phenyldopam is a drug.
Excuse
What?
me.
Yes.
As nitroprusside, it causes vasodilation of arteries and veins.
Yes.
So it causes decreased preload and outload. So what would happen to the stroke volume? This is going to be decreased. So is it going to be the same with sodium nitroprusside?
Okay, so when you are giving the patient sodium nitroprusside, right, so both the decrease, so the both the preload and afterload is going to be decreased, right? And when the preload and afterload both are decreasing, the stroke volume is going to be decreased, right? Because the stroke volume depends both. The stroke volume depends upon the preload and afterload. So the lower is the preload, the lower is going to be the stroke volume. The lower is the afterload, the lower is going to be the stroke volume. So this is how basically nitroprusside is going to function as well. Nitroprusside is going to decrease both of those things, and when as soon as possible both of those things decrease, the patient is going to have low cardiac output, right? So this is how nitroprusside is work. Now we have another drug which is the phenyldopam, right? So phenyldopam is a dopamine D1 agonist, right? Now what is important regarding this drug is this drug acts on the coronary vessels and it acts on the arteries as well. But the most important thing is that it acts on the renal vessels as well, right? So it acts on the renal vessels as well. This is very important. Keep this thing in your mind. Why? Because I'm going to tell you in 1 second, right? So if you look at a lot of drugs, you will see that um, a very big amount of drugs don't act on the renal vessels, right? So they are not going to cause any renal changes. But phenyldopam is going to cause vasodilation as well, and it is going to cause another thing as well. And that is when it acts on the renal vessels, it is going to cause increased amount of blood flow to the renal vessels. And when increased amount of blood flow occurs in the renal vessels, all the sodium is going to get out of the blood body, right? All of the sodium is going to go out of the body, and as soon as all of the sodium goes out of the body, you are going to have low blood pressure, right? So as soon as all of the sodium gets out of the body, you are going to have low blood pressure. So phenyldopam is a drug that acts by reducing the BP and causing natriuresis as well, right? Now, okay. So I'm gonna ask you, why is gonna be the pulse oximetry normal in why is the pulse ox normal in cyanide poisoning? Right. So the pulse ox is normal in cyanide poisoning because if you look at the biochemistry, right, and we have the cyanide poisoning, you will look at one thing. Cyanide blocks the complex 4 of the ETC, right? So there is a chain that was known as the electron transport chain, and cyanide blocks block the complex 4. And what was the complex? So the complex 4 was using oxygen to generate energy, right? So the complex 4 was using oxygen to generate energy. So the complex 4 was using oxygen to generate energy, right? So this was the most important thing in our body. Why? Because we need oxygen to form to run this complex 4. As soon as we give oxygen to this complex 4, we are going to get a lot of energy in our body. But what if this oxygen is not present? The complex 4 is not going to run. A lot of cells are going to go into ischemia because you are not having enough ATP. That is why oxygen is important to our body. But what if I say to you that we have all the oxygen in the world, but the complex 4 is not working? So the oxygen is not going to be used. So what will happen to the oxygen? Will it be normal or will it go up?
Up.
Yes, so it is going to go up. So the pulse oximeter is going to be 100% normal. But paradoxically, the patient is going to have very much respiratory symptoms, and the patient is going to have respiratory symptoms, or the patient is going to have ischemia as well. Right? So that is what will happen in cyanide poisoning. Right?
And the
Okay, so
second mechanism of Dr. Moss, the SpO2 calculate the oxygen binding with the RBCs. That's why there is no defect in the oxygen binding with the RBCs.
yes, exactly. So the SpO2 is going to bind there as well, and that would be the same thing as well. But the main thing that you keep in mind here this thing, right? So since oxygen is no longer being used, right? So it's not going to go down, right? So, but at the same time, the lactic acid is going to be high. Why? Because if you're not using the oxidative phosphorylation, you are relying on the anaerobic respiration, right? So, in any case, whenever you are relying on anaerobic respiration, the lactic acid is going to go down, is going to increase in that condition, right? So, the lactic acid is going to increase in that condition, right? So, now there was a thing. As someone told us, so let me tell you one more thing. Right? So there is two things, right? One thing is known as the pulse oximetry, right? And the other thing is known as the co-oximetry, right? So there is one thing which is known as the co-oximetry, and the other thing is known as the pulse ox, right? So the pulse oximetry just measures the hemoglobin. So the pulse ox is just going to measure the hemoglobin, right? How much hemoglobin is saturated, how much hemoglobin is not saturated, right? So it is going to measure that. This is known as BSPO2, right? And in a lot of conditions, the SPO2, the hemoglobin is going to be normal. It's going to be oxygenated. So the pulse oximeter is going to be normal, right? But what is co-oximetry? Co-oximetry measures other things as well, right? So it is going to measure carboxyhemoglobin as well, deoxygenated hemoglobin as well, and methemoglobin as well. So whenever a patient is having carbon monoxide poisoning, so basically pulse oximetry is measuring how much hemoglobin is attached to your, how much hemoglobin is attached with something, right? It's very simple, right? So pulse oximetry is measuring how much hemoglobin is attached to your pulse, is attached to something. So, for example, if a patient is having carbon monoxide poisoning, we are not talking about cyanide poisoning. If a patient is having carbon monoxide poisoning, so what will happen is that now these patients, uh, now these patients are gonna have hemoglobin that will be binded with carbon monoxide, right? So when you look at the pulse oximetry, it is gonna be normal, right? It's gonna be normal. It's gonna be 100%, right? Okay, so I was telling you that so of carbon monoxide poisoning, if you look at the patient's hemoglobin is going to be binded with carbon monoxide, and when you look at the patient's pulse oximeter is going to be normal. Then what we do is that we change the pulse oximeter to co-oximetry. Co-oximetry is going to tell us oxygenated hemoglobin, not binded hemoglobin, right? So now the oxygenated hemoglobin is below, and the carboxy hemoglobin, which will be formed by carbon monoxide, is going to be high. So that is how we will differentiate in the form in this, right? So in carbon monoxide poisoning, pulse oximeter is going to be normal, whereas the carboxy hemoglobin in the co-oximeter is going to be abnormal. In case of cyanide poisoning, if you look in the case of cyanide poisoning, both the co-oximetry as well as the pulse ox, both of them are going to be normal, right? Why? Because you are not having any problem with the oxygenation of hemoglobin. You have all the oxygen in the world, right? Let me pull up the picture here if I can. This was the glucagon thing. I don't think they have it here anymore. But let me see. Yes. Right. So if you see, this is the complex 4 of the electron transport chain, right? So this is the complex 4, right? So this is the complex 4. And what do you see here? You see here that oxygen is combining with hydrogen, it is forming H2O, right? And then this whole, right? So this is what is going to happen, right? And then you are getting H positive as a result of this, and this H positive is going to go here and generate ATP. But if I block all of this process here, the patient is not going to form any more ATP, and the problems is going to fix. So yes, Dr. Aksa, what was your question?
I actually have two questions now. Can you repeat co-oximetry?
Okay, and the second one?
And the second one is, can you repeat the drugs that are safe to use in pregnancy?
Okay, guys. So So pulse oxy. So first of all, let me tell you pulse oximetry. So pulse oximetry is a procedure. It is very simple. So when you have gone to the hospitals, you are gonna see that the patient has a thing in his finger, and that thing is generating red light. That is known as the pulse oximetry. So that is basically infrared light, and that infrared light sees how much amount of blood is binded. So how much hemoglobin is binded to something, right? And the greater amount of hemoglobin that is binded to something, the greater will be the pulse oximetry. And normally hemoglobin is binded to oxygen, so we think that this patient is having normal pulse oximetry, so that is pulse oximetry. But there is a condition which is known as the carbon monoxide poisoning, and in carbon monoxide poisoning, carbon gets binded carbon monoxide gets binded to the hemoglobin. So now if you run the pulse oximetry, that pulse oximetry is going to show binded hemoglobin, and the pulse oximetry will be normal. Then we do another type of laboratory study. So now this is not done with some kind of finger test or some kind of device. So now we take the blood of the patient and we check the hemoglobin, different hemoglobins, right? So now we send the hemoglobin to a spectrophotometer, and that spectrophotometer is going to see the different types of hemoglobin. It will tell us how much hemoglobin is binded with carbon monoxide, how much hemoglobin is binded with oxygen, how much hemoglobin does not have anything, how much hemoglobin is binded with methemoglobin, and how much hemoglobin with binded self hemoglobin, right? These are all different types of hemoglobin, and the test is going to tell us, right? And if there is any difference between the pulse oximetry and the co-oximetry, it is gonna mean that the patient is having carbon monoxide poisoning or methemoglobinemia and a lot of other conditions. Don't worry, when we do the respiratory system, we are gonna go into the details of those things in the physiology, right? So we are gonna do the PaO2, the SpO2, the co-oximetry, the carboxyhemoglobin, and all of those things, right? So I was just giving you a touch up here because if you integrate the things here, then the things are going to be easier in the next systems, right? So the first system is going to be the hardest, and the last one is going to be the easiest. And the second question, what are the drugs that we can use in pregnancy, right? So the drugs are nifedipine, right? So the first drug is nifedipine that you can use, right? Nifedipine, labetalol, hydralazine. Methyl dopa is not preferred anymore. So these are the three ones: hydralazine, labetalol, and nifedipine. Methyl dopa is second line. It's not the first line drug for the treatment of hypertension in pregnancy, right?
Thank you.
Welcome. Any other question, guys? The picture came. Okay. Hey guys, so we'll keep it till here today. To tomorrow, the main thing that we're gonna do is the AV notes and the all the anti-arrhythmics. So we are gonna revise the
Dr.
arrhythmias
Moss,
and the yes,
Dr. Moss, I have one question.
yes.
I have really one. So, as you said, the nitrate reduce blood pressure by, as it is vasodilator, so it reduce the blood pressure. So that case we use it in angina or so, and because it's reduce the chest pain. So how does it reduce the chest pain by reduce the oxygen supply or increase or like reduce the demand, oxygen demand? Could you just clarify this point little bit?
Okay, so this is a very important and very good question, right? So this is a very thoughtful question. So remember, nitroglycerin does not increases the blood supply of the heart, right? Nitroglycerin never increases the blood supply of the heart. Nitroglycerin is only gonna reduce the preload of the heart. So less amount of blood is gonna come into the heart. And when less amount of blood is gonna come into the heart is going to contract with less force. And as soon as the heart contracts with less force, you are gonna need less amount of oxygen, right? And when you need less amount of oxygen, the pain of the angina is gonna go away because the pain of angina is related to the oxygen consumption. So nitroglycerin is nitroglycerin is indirectly reducing the oxygen consumption by decreasing the amount of blood that comes into the chambers of the heart. And when the blood is decreased that comes into the chambers of the heart, you're gonna have less amount of work to do. And when you do the less amount of work, there was gonna be less pain, right?
Yeah, okay. That means it reduce the oxygen supply, like demand.
Yes, it reduces the oxygen demand, not the oxygen supply, right?
Oh yeah,
It
demand.
has no effect on the oxygen supply.
Yeah, okay. Thank you.
Welcome. Well, you're welcome,
So what did
Dr.
you just say that nitroglycerine does not decrease what?
Nitroglycerin reduces the oxygen supply, oxygen demand of the heart, right? It has no effect on the oxygen supply of the heart, right? So if they give you a question and they say, and this is a question that is going to come into the U world a lot, right? So if they are going to say the patient is having angina, and all of a sudden you give the patient nitroglycerin, right? And now the patient's angina has gone away, and they will give an option that what to the decrease in the angina. And first option that a lot of people are going to mark is increase in oxygen supply of the heart, but that is not true. Nitroglycerin has no effect on the oxygen supply of the heart, right? It does not affect the oxygen of the heart. It is only gonna reduce the amount of blood that comes into the heart, and when the amount of blood that comes reduces, then you are gonna have less amount of contraction, and less amount of contraction will need lesser oxygen, and that is gonna solve the problem, right? So just think, if you have a car and that car is consuming a lot of fuel, right? Now, when the car consumes a lot of fuel, you're gonna have to spend a lot of money, and that money pains you, right? That money is paining you. You're having physical pain and emotional pain because of using a lot of money on the car's fuel. Now, there are two ways that you can fix this problem. One way is that you use the car. The one way is that you put more fuel into the car, but that is not gonna solve the problem. The other way is that you can reduce the amount of usage of your car, right? So when you reduce the amount of usage of your car, so for example, if your car uses, so even if the car, so for example, if four people are sitting in the car, you just make one people sit in the car, and that is going to increase the car's economy, right? And when the car's economy increases, you are going to use less fuel, right? So you are going to use less fuel, and that is going to solve the problem. So this is how nitroglycerin works, right? So you're going to reduce the fuel consumption of the car by making the car more efficient, right? So this is what we are going with nitroglycerins, right?
Yes, thank you.
Yes, sir. Thank you so much.
You are welcome. And remember the same thing. Okay, Dr. Sana, I think I will make a graph tomorrow, and I will explain those things in the detail in the graph tomorrow regarding the HB things, right? Okay. Now, one more thing is that sildenafil causes the same thing as well, right? So sildenafil causes the same thing as well, and that is a PDE5 inhibitor. That is why we don't combine two things at the same time, right? So we don't combine two things at the same time. So we do not combine sildenafil with nitroglycerins. Then that is going to cause a lot of problem. So we'll keep our lecture till here today, and we'll start from tomorrow, right? Okay, guys. So take care and have a good day. Bye bye.
Thank you.
Thank you.
Please, are we going to have a microbiology session today? Anyone knows?
Did we have Dr.
Hopefully, yes, but it's still early regarding microgen session. They will do after Dr. Ahmed lecture, and today we not, yeah, so we didn't have this word session.
Was there any revision on a UWell question today?
No.
No, okay, thanks.
Class today.
I was wondering, I said maybe I lost something. Okay.
No, we started late actually.
Guys, what
Mhm.
happened to Discord and the East and West and Asian times? Any updates?
I don't think so. But there was a lecture around. There was an extra lecture. Based on my own time in here, I saw that there was a link that was passed around 1 a.m. 1 a.m. Saudi time. So I'm not sure.
Okay, so this is it. Is it remaining micro?
Yes, I think.
Okay. Lock off.
Sorry, guys, but we have another meeting today, or that's it? Somebody knows? Hello? Hi.
Hi guys, does anyone want to a class from Dr. Moss regarding neonatal or fetal circulation and the pathology regarding that?
Hello, am I audible?